Hello, my name is Dr. Majid Hamid Al Aboud, and this is the second lecture of session 5 of the respiratory module, and I will talk about the lower respiratory tract infections and pneumonia. So we have 7 learning objectives in this lecture. First of all, I will define pneumonia and distinguish between the different types of pneumonia. Then I will describe the infectious etiology of acute community-acquired pneumonia and acute hospital-acquired pneumonia. And then I will talk about the etiology of each of these and how we can identify the pathogen for each one. And then to understand the spectrum of a clinical feature of acute pneumonia and the principle of collection of a specimen for laboratory diagnosis. And then I will list the common opportunistic pathogens causing pneumonia in the immunosuppressed host. And finally, I will describe in principle the antimicrobial therapy used for the treatment of pneumonia. Pneumonia is defined as inflammation of the gas exchanging region of the lung, that is the lung parenchyma. So an inflammation of the lung parenchyma is called pneumonia, and usually it is due to infection by a microorganism. And we have another term called pneumonitis. And pneumonitis again is inflammation of the gas exchange region of the lung, but it is not due to infection rather than it is due to other causes such as physical or chemical damage. For example, if a patient drink kerosene nafat accidentally, this kerosene when enters the lung will cause a chemical inflammation. In that case, we don't call it pneumonia, rather we call it pneumonitis. In general, we can classify pneumonia according to the uh, duration of pneumonia, duration of onset of pneumonia into acute and the chronic. And you know, acute means within days or a week, and the chronic means within a week, within weeks. And acute pneumonia is further classified into either lobar, bronchopneumonia, interstitial pneumonia, or aspiration pneumonia. Okay? So let's start with the most common type, which is lobar pneumonia. And as the name lobar means, it is confined to a lobe of the lung. Only one lobe of the lung is affected. So it is localized to a particular lobe of the lung. And as you can see here, in this PA view of a chest X-ray, the right middle lobe is affected. You can see here opacity, which is typical of consolidation or pneumonia, localized to the right middle lobe of the lung. And on the lateral view chest X-ray, this is how the right lobar pneumonia looks like. So right middle lobe pneumonia. And the other type of pneumonia is called the bronchopneumonia. And the bronchopneumonia usually more diffuse and patchy. And it is often affecting both lower lobes of the lungs. So it is not localized to one lobe like in lobar pneumonia. Bronchopneumonia, usually both sides of the lung are affected, and usually the lower lobes are affected more. Another type of pneumonia is called aspiration pneumonia. And the term aspiration means when somebody aspirates something, that is, swallow something accidentally, and that thing passes to the lung. For example, in children or in those who are who are unconscious So whenever they aspirate food, drink, their own saliva, or vomit, sometimes severe vomiting, the patient will swallow his vomit and will aspirate the vomit into the lung. So those with altered level of consciousness, those in coma, or those after surgery and after general anesthesia, so still they are not fully conscious, or those who are intoxicated or with alcohol, they are semi-conscious and they are vomiting a lot, or those who have drug abuse, they are using some sort of drugs that causes alteration in the level of consciousness. Another cause for aspiration pneumonia is the swallowing related problems due to neuromuscular disease, such as myasthenia gravis or motor neuron disease affecting the muscles of the swallow. Again, those with esophageal disorder, problem with the esophagus, they might have aspiration pneumonia. Another type of pneumonia is called interstitial pneumonia. And interstitial pneumonia is often associated with connective tissue disease. And by connective tissue disease, we mean diseases that affect the connective tissue of the body, like rheumatoid arthritis, systemic lupus erythematosus, scleroderma. These connective tissue disease, if they are associated with pneumonia, we call it interstitial pneumonia. Also, interstitial pneumonia might be associated with certain drug abuse. Side effects of some of the drugs might cause interstitial pneumonia, and sometimes chronic hypersensitivity pneumonitis can cause interstitial pneumonia, and HIV infection or AIDS can be associated with interstitial pneumonia, or sometimes we call it interstitial pneumonitis. And there is another classification of pneumonia according to the etiology. So if the pneumonia is acquired while the patient is doing his usual daily activity, we call it community-acquired pneumonia. So it is a pneumonia that is acquired while the patient is outside the hospital doing his daily job. The second type is called nosocomial pneumonia, and nosocomial pneumonia is hospital-acquired pneumonia. So here the patient is admitted to the hospital for another reason, for example, to control of diabetes, or for doing a surgery, or for other disorder. But while he is in the hospital, he acquired the pneumonia. We call it hospital-acquired pneumonia. Because as you know, in the hospital, there are other patients with pneumonia, and one may transmit the infection to another. A third type of pneumonia is called pneumonia in the immunocompromised patients. And the term immunocompromised means that the immunity is not good in that patient. So people with low immunity, like people with HIV or AIDS, people who are using chemotherapy for cancer, people who are using immunosuppressive treatment for diseases like rheumatoid arthritis or systemic lupus erythematosus, all of these are immunocompromised. In addition, people who are on long-term steroid use, again, they are immunocompromised, and they might get this special type of pneumonia, which we call it pneumonia in the immunocompromised patient. And the fourth type is aspiration pneumonia, and I explained the term aspiration pneumonia. And from the type of pneumonia, somebody may ask why we should know the type of pneumonia, why we classify pneumonia, because from the type of pneumonia, we can suspect the type of microorganism causing the pneumonia. And therefore, if we can suspect the type of microorganism, we can prescribe the best medication, which is called the empirical treatment. according to our suspicion of the type of microorganism. For example, in community-acquired pneumonia, the most common microorganism is Streptococcus pneumoniae, followed by Haemophilus influenzae. Sometimes we call it H. influenzae. Thirdly is Klebsiella pneumonia, which is gram-negative pneumonia. Staphylococcus aureus, Streptococcus pyogenes, and Mycoplasma pneumonia, Chlamydia pneumonia, and Legionella pneumophila. So this is the order of microorganism according to its prevalence in the community-acquired pneumonia. This is a sputum of a patient that was stained by gram stain, and as you can see here, very clear in these arrows shows the what is called the Streptococcus pneumoniae. So they are arranged in strips, okay? So they are like a chain, and they are gram positive. So this is very characteristic of Streptococcus pneumoniae, is a diplococci. So they are arranged in chains, usually 2 of each, and we call it a gram-positive Streptococcus pneumonia. Well, the hospital-acquired pneumonia on the other side, which we call it nosocomial pneumonia, the most common microorganism here is not Streptococcus pneumonia, but gram-negative bacteria, like Klebsiella, Pseudomonas, and Escherichia coli. Why? Because these are the types of microorganisms that are very common in the hospitals. And the patient will get these microorganisms from the hospital while he is being admitted for another reason, as I said. The second most common type of microorganism causing nosocomial pneumonia are Staphylococcus aureus, which is called the methicillin-resistant Staphylococcus aureus. Why methicillin resistance? Because they are not responding to methicillin, and methicillin is an antibiotic. So we call it methicillin-resistant Staphylococcus aureus. And thirdly, we have the Streptococcus pneumoniae, the same microorganism, which is the most common cause of community-acquired pneumonia. And fourthly is the anaerobes. And you remember the anaerobes, they are living in areas with low oxygenation. And finally, we have the fungi. While an aspiration pneumonia, as expected, because it is due to aspiration of vomit or saliva, so we should expect that the type of microorganism here is the oral flora, the bacteria that lives inside the oral cavity. And then we have the anaerobes. While those who are immunocompromised, such as people with HIV infection, the commonest type of microorganism causing pneumonia is called Pneumocystis jirovecii, followed by Aspergillus species, and then by a virus called cytomegalovirus. So what are the clues for the underlying cause or the microorganism of a pneumonia, so that we can start empirical antibiotic without waiting for the result of culture and sensitivity? We have many clues. One of them is the age of the patient. So in the elderly, usually the type of microorganism is different from that in the young. Second is community-acquired or hospital-acquired. If it is community-acquired, usually it is Staphylococcus aureus. If it is hospital-acquired or nosocomial, the microorganism usually is gram-negative. Third is the presence of a chronic lung disease. Those with a chronic lung disease are more prone to certain types of microorganisms. Fourth is the immunosuppressed people. As we said, people who are immunocompromised, Pneumocystis jirovecii pneumonia is the most common culprit. Those who own pet like cats, dogs, birds, other animals, According to the type of pet, we should suspect the type of microorganism. So a very important question that we should ask the patient, do you have pet at home or not? Travel history is very important. And we are living now in the era of COVID-19 epidemic. At the beginning of the epidemic, the travel history to China or Italy was very important because if your patient was just coming from China or Italy, the most likely microorganism would be the SARS-CoV-2 or the coronavirus. So travel history is very important because in certain parts of the world there are common microorganisms abundant in that area. So travel history is very important. Now, what are the main symptoms of pneumonia? So we have systemic symptoms, common symptoms like high fever and chills. And chills is this shivering movement of a patient with fever, and all of you have experienced this symptom. Then we may have some symptom related to the skin or signs like cyanosis sometimes. And the patient usually is coughing with sputum, sometimes we call the phlegm. Shortness of breath is very common, and dyspnea. Pleuritic chest pain, and by pleuritic chest pain we mean a stabbing pain like a knife in the lateral aspect of the wall when the patient takes deep breath or cough. This is called pleuritic chest pain. It is very characteristic of pneumonia, especially lobar pneumonia. And sometimes the patient might cough blood in the sputum, and here we call it hemoptysis, that is coughing of blood. And of course, the patient, because of fever, will feel fatigue and aches and pain in different parts of his body, and there is loss of appetite, headaches, mood swings, and we may find low blood pressure. And low blood pressure is one of the signs of severe pneumonia. And because of fever, we should expect there will be high heart rate, tachycardia, and the patient might have nausea and vomiting, and he might have joint pain because of the fever. And we have a very important scoring system, we call it CAP 65. And CAP 65 score is very important to assess the severity of pneumonia. Why? Because according to this score, we can decide whether to treat our patient with pneumonia at home, or to admit him to hospital, or to admit him to the intensive care unit. So what is the CAP 65? At this letter CAP, each letter represents a word. So C is confusion. U stands for urea. Any blood urea of more than 7 millimole per liter or more than 42 milligram per deciliter is one sign, one scoring point. R stands for respiratory failure. Any heart rate more than 30 per minute is 1 point. B stands for blood pressure, as I said. So a systolic blood pressure below 90 or diastolic blood pressure below 60 is 1 point. And the 65 stands for the age. Those with age more than 65 years, this is a point, which means the elderly by itself or getting a older age is a risk factor. So one point is scored for each of these scoring points, and then we calculate the number. If it is 0 or 1, it's likely to be suitable for home treatment. If it is 2, then you should consider admitting your patient to the hospital, and you may make the patient to stay for a short time, or you may decide to treat him as an outpatient. If it is a 3 or more, then it should be treated as in hospital because this is severe pneumonia. And sometimes Even the patient might need admission to the intensive care unit, especially with high CARB 65 score like 4 or 5. So how do we diagnose pneumonia? The most important thing after history and examination is to identify the microorganism causing the pneumonia. And here we can achieve that by doing throat swabs, taking swabs from the throat of the patient, or nose swab. Now in the COVID-19, we do nose or throat throat swab. Sometimes we do nasopharyngeal aspirate, especially for viruses. So we take aspirate of the secretion from the nasopharynx. Sometimes we take swab from the nose only, what is called pernasal swab, especially for pertussis. And sputum examination is very important, so we ask the patient to provide us with sputum and we examine it. Sometimes there is no sputum, so we do what is called the bronchoalveolar lavage fluid examination by introducing a bronchoscope, and we do lavage or wash of the bronchoalveolar area, and we take that wash out. Sometimes, but rarely, we may need lung biopsy, a biopsy taken from the lung. Examination of the urine, especially for Legionella pneumonia, might be helpful. Blood culture is very important, so remember to withdraw blood culture for those who are highly feverish and needs admission to hospital. And finally, we may do serum examination, a clotted blood, looking for viral pneumonia, like the rapid test that is now used for the detection of COVID-19. How do we manage pneumonia? We have general measures and the specific measures. The general measures, first of all, is to emphasize the importance of good oral fluid intake. So we ask the patient to drink a good amount of fluid, water and other types of fluid. Second is to give antipyretic, a treatment for fever or fever reliever, and very commonly used is the paracetamol or the acetaminophen to reduce fever and pain. And third is to give a stronger analgesic for pleural pain. Remember, the patient is suffering from pain, pleuritic chest pain, which is a very severe pain and needs good analgesia to relieve that pain. So we give what is called painkiller, like non-steroidal anti-inflammatory drugs. Example of it is ibuprofen or Voltaren, diclofenac. Then it's very important in severe cases to give intravenous fluid and oxygen, because the patient usually is unable to drink fluid. So we give fluid by intravenous route, and we give oxygen because the patient will have hypoxia. These are the general measures. The specific measures is the antibiotics. And in the antibiotics, again, as I said, it depends on our suspicion of the microorganism. So in community-acquired pneumonia, usually we give penicillin. But in hospital-acquired pneumonia, we usually give another antibiotic called co-amoxiclav. And thank you for listening.